IVM.
I want to thank Intel for supporting our show. Do you remember last year when we spoke about how the Intel vPro platform is built for business? Well, I'm glad to say we've kicked it up a notch. That's right, Intel is back with a new and improved version of the platform. The new Intel vPro platform lets you do more of what you want and less of what you don't. So it's better for you and for your IT teams, who really are the backbone of keeping your work-from-home experience easy and enjoyable. I can safely say that the new vPro platform gives you more enterprise efficiency with less constraints. Visit intel.in/morewithvpro, that's VPRO, to discover how you can get more done with less waiting. If you're listening on the IVM Podcast Android app, click the link that's visible to you now.
Welcome to All Things Policy, a daily podcast by the Takshashila Institution. We are a bunch of policy nerds based in Bengaluru, and we like bringing fresh perspectives to Indian affairs and Indian perspectives to global affairs. So grab a cup of coffee, sit back, and join us for today's chat.
Hello and welcome to All Things Policy. I'm Prateek, and today I have with me Shambhavi and Sunila, and we're going to be talking about the National Digital Health Mission today. So a couple of weeks ago, the Ministry of Health and Family Welfare outlined its vision to create, and I'm just going to quote here from the website, which says, create a National Digital Health Mission that supports universal health coverage in efficient, accessible, inclusive, affordable, and timely and safe manner. Right? And they also go on to say about how this is going to ensure security, confidentiality, and privacy of health-related personal information. And the health minister has also commented on how this is going to radically change the health landscape of this country. Right. So before we go into the specifics, right, I guess, Shambhavi, Sunila, can one of you tell us about how this whole thing has come about and, why are we here today?
Thanks, Prateek. So first, in 2017, the Ministry of Health and Family Welfare, it came up with the National Health Policy. And one of its objectives was to digitize the healthcare system of India. So following the National Health Policy of 2017, the government of India came up with the National Digital Health Mission. So they were planning to enforce this mission by creating digital health records and creating and maintaining registries for healthcare professionals and health facilities, so that there would be interoperability and the data could be exchanged smoothly without any difficulty. Following that, it came up with the National Digital Health Blueprint in 2019, which recommended a federated architecture instead of a centralized architecture for management of health data to ensure interoperability, technological flexibility, and independence across the national digital health ecosystem. So according to this federated structure, the data will be collected at 3 levels, that is central, state level, and lastly at the health facility level. So following all these developments, the government as in the Ministry of Health and Family Welfare has now come up with the Health Data Management Policy, which according to them is the first step in realizing the National Digital Health Mission's guiding principle of security and privacy by design for the protection of individuals' data rights.
Okay, and what exactly, from your reading of the policy that's come out, right? What do you guys think? What are the key features of it, and how will it radically change the health landscape, or will it?
The good thing about the policy is that it actually focuses on the informed consent aspect of the data protection, because when you take information from someone, you need to have their permission, right? So it focuses on that, and it gives complete freedom to the data principal. Data principal is the one who actually provides the personal health information. So that is a good thing about the policy.
Thanks, Sunila. So if you look at the health ecosystem in India, right, there's a lot of information asymmetry per se in terms of health services available, the pricing for health services, for example, and even for individuals to keep all medical records in one place and to be able to go to a doctor with all of those medical records sometimes to get a good and effective service based on their personal history, right? And I think the idea behind NDHM is to make that information asymmetry go away to an extent, and be able to offer better health services based on visibility. Whether the NDHM actually will do that or not is a very different topic, because that has to be based on the way our health ecosystem currently works. This policy, the one that we are talking about today, the data management policy, is basically trying to figure out a way that we can manage whatever data we are gathering to reduce the information asymmetry. So if we focus on that aspect itself, that is also a little problematic, because the policy itself does not actually take into account the fact that they're looking at health data. You can actually take out the word health from it, and it seems as if it's any data protection legal contract that could be signed between two individuals or an entity and an individual. It actually boils down to something of that simplistic nature. It doesn't account for the purposes for which health data could be taken. It basically says that the data principal, as Sunila was saying, is the owner of the data, but it does not allude to what the data is going to be used for at all. So in that case, I think it seems like a placeholder for the broader data protection bill that we're all waiting for, that has been highly debated over the past many years now. It seems to be like a document more than a policy, and it seems to be like a placeholder for the argument, hey, but we don't have a data protection bill, so how can you be collecting health data? And the counter to that argument is, no, we have this policy that all your data is protected. I don't think this is sufficient. It is definitely not sufficient. We have definitely not have sufficient debate on the idea of taking all of this health data and what's to be done with it. But even on the particular point of how health data should be collected, I don't think this policy is sufficient.
Yeah, and I think that's a good point that you make, right? And normally a critique that we hear is, hey, you don't have data protection framework in place, so how can you be doing this, right? And it seems like, in the midst of a pandemic, you need to have some sort of policy in place. But another question that I wanted to ask you is that, do you think that the way this is structured right now, right? And you made a good point of that. You can remove the word health, and it will still pretty much read the same. But with that context, do you think it reflects the state of the health infrastructure and the health ecosystem in India at all? Because again, this has to ideally build on top of a real world system, right? This is just a layer on top of that in an ideal case. But from your reading of it, how well do you think it fits with that?
Right. It doesn't at all. I mean, this fits into a system such like the UK's NHS, right, where you have clinics which are all under NHS. So you understand that there's going to be a standard of care which is going to be universal there. And then you go to a clinic and you get the same kind of data out that you can then take on to another clinic, which we don't have here in India. I mean, we don't have the basic governmental infrastructure to deliver health services which can be universalized. We have family physicians. We have so many different types of medicines being practiced that how do you even collect that data? How does one doctor make sense of somebody else's readings is beyond my understanding. The cost to a general practitioner to now move from the system that they have set up to a possible online setup where they actually might be the data fiduciary as well. I mean, from a big hospital point of view, it makes sense to hold data. And I think big hospitals anyways hold data to the extent possible. But the normal GP who has a little clinic, the cost for them to move to this is going to be tremendous. To move and maintain to this is going to be tremendous. And if they do not move, then the question we have to ask ourselves is it even worth doing an exercise of this sort? Because we do even know the proportion of people who go to just these GPs. And I mean, think about it in villages, right? So I come from a village in Maharashtra. We don't even have a doctor. We have someone who comes visiting on a scooter every week or so. And anyone who's ill basically calls him and asks him to stop by at their house. How do we expect this guy to be part of the NDHM and to follow this data policy is a little beyond me. That's from the particular data policy angle. From the health angle as well, there are certain gaps in this document. For example, they have this section on sensitive personal data. And I don't think this means that all of this data will be collected. I think there has been some misreading of this in some reports that all of this data will be collected as part of the NDHM. I don't think that is what they plan to do. I think they were just trying to say that this is sensitive personal data and should be treated as such. But even the language that they've used is really funny. I mean, they say transgender status instead of just gender. I really don't understand where that has come from. You could probably just get away with saying gender, right? Why transgender status? Then they speak about caste or tribe, and again there has a health angle to taking caste or tribe data, because we know that certain communities are predisposed to diseases. So in some ways, it does make sense to have that kind of data. But yeah, I think you did not have to put it in the way it has been put in there.
Adding on to that, I think it's not just the lack of health infrastructure, but it's the lack of legal infrastructure as well. Because this policy, it states that the consent of data principle will be considered valid only if it complies with the standards that are set out under the Indian Contract Act of 1872. And that act is just a generic act which prescribes the law relating to contracts in India, and is the key act regulating the contract law. So, I mean, this contract law, when you take informed consent, especially in the healthcare sector, it has different implications from any other informed consent, because health is a very serious matter here. Indian Contract Act doesn't have any provisions relating to consent in healthcare. So I guess even that is lacking here. So we need to have some laws which are pertaining to specifically informed consent in the healthcare sector.
Right, and I'm just going to add on to that as well. So we already have guidelines that control ethics, at least in research. And a lot of that data pertains to health. So I think we also have to see how this will marry with those existing guidelines. The one thing that stood out for me from these guidelines was the concept of consent manager. Because for all other guidelines that are related to health per se, the consent manager is usually your doctor, especially when they're enrolling you in a trial. It is the responsibility of the lead scientist or the lead doctor to make sure that people understand what they are enrolling into. Obviously, for a clinical trial, there's a massive more landscape than just saying that we're going to keep your data in a database and will be used for specific purposes. But it is up to the doctor to make sure that the people understand what they're giving their data for. And since with the data policy, the purpose itself is unsure, they also talk about this concept that you should have a consent manager, which can be a person or an entity. So very much like the apps that we use, where we do agree or I do not agree, kind of like that. Except the fact is that here you're looking at somebody's health data, which not only impinges on them, but very likely on their family members as well, right? So if I say I have a history of blood pressure, and that is related to some genes that I have, which means that my siblings also might have high blood pressure, right? So I'm not only consenting to give my data, but also their data.
Yeah.
Inferences can be made about them based on my data rather. And so it is very necessary that whoever is giving or taking that consent ensures that the person who is giving data understands this, right? So you can't just have an interface that says, I agree, I do not agree. It has to be more than that when it comes to handing over at least certain aspects of the health data.
Yeah, and from my reading of it, it seems to be that it's structured more for the latter, right? Where it's an interface and not necessarily a person that's managing it.
Yeah.
And Sunila, I think you were also mentioning before we started something about a data retention or an archival policy. Do you want to talk a little bit about that?
Yes. So I think when we are talking about analyzing the aspects of this policy, I think it is important to note that they have already mentioned in the document that this policy should not be read as a standalone document, and that it should be read along with the National Digital Health Blueprint, the Information Security Policy, and the Data Retention and Archival Policy. The interesting thing here is that they haven't formulated these policies yet. So whatever way we analyze this policy, I think it will be incomplete unless we actually get to see those other policies as well. So.
Okay, that's interesting. So I was doing some reading about this as well, right? And I think some of the things that came across was that there also doesn't seem to be a very clear linkage in terms of how this will interact with the data protection bill itself, right? I don't believe that's explicitly called out. Whether, and you can always have that debate on whether the right approach to data protection is whether you go horizontal in one wide policy covering everything, or you lay down principles in one policy, and then you have sectoral regulation, right? Like we've sort of been doing with finance. It isn't clear whether this is exactly that, a sectoral regulation per se, because there is mention of a data protection authority as well, specific to health data in the document itself, right? But it's not really clear of how this is going to play with the personal data protection bill. There's also another thing that was interesting to me, which was the personal data protection bill makes a distinction in different class of fiduciary, right? You have a normal data fiduciary and you have something that's called a significant data fiduciary, in which you impose additional obligations such as data audits and etc. Right? This seems to hold everyone to similar standards of a significant data fiduciary, which is probably understandable given that it's held data. But again, going back to what Shambhavi you said, right, in terms of how this is going to impact a general practitioner or a family physician or the neighborhood clinic, how they will comply with this or what cost this is going to impose on them, whether they choose to opt in or opt out, that remains to be seen, right? Because I think another thing that's interesting is that they've taken pains to state the voluntary nature of this, right? Which is interesting. I say that, it's a podcast, so you can't see me doing air quotes. But it is certainly interesting in the sense that there is this intention to just make sure that there isn't any misunderstanding on that front, that it's going to be voluntary, you can opt out, or even to the extent of saying that you will not be denied any healthcare services because you don't have an health ID or you don't have an Aadhaar.
It's like Arogya Setu.
Exactly, right? So, that's a different thing.
But it is so voluntary nature, but hey, you're going to require it.
Exactly. Okay, yeah. In that sense, yes, right? So, exactly. So they've been at pains to point out that it's voluntary, but how this gets implemented again is a different thing. Yeah, and I think that's where you're...
I think an opt-out system is not the best way of approaching this anyways, and approaching any consent related thing, right? I remember having this conversation also for the data protection bill, because initially that had an opt-out mechanism as well, and there were a lot of discussions that you cannot keep an automatic list and where you can opt out of. People have to be able to opt in and choose with informed consent to be part of something.
Yeah, I think a great example of informed consent, or the lack thereof, right? And I'm going to go on a slight tangent, was what happened with the admit cards, right? We basically said that, hey, if you've downloaded the admit card, it means you want to you're showing a strong desire that you want to attend, you want to take part in the exam and this and that, when it's not really the same thing at all, right? So yeah, again, I agree that I'm going off on a slight tangent, but I think it's important to understand the ecosystem of how informed consent works in society as well, right?
Yeah. And if my doctor sees, I remember having this conversation at the time of discussing ethics in clinical trials, and many of the doctors were trying to figure out a better mechanism for getting consent, because from their point of view, the patient is completely and totally vulnerable and completely dependent on the doctor. If the doctor says, hey, this clinical trial is good for you, they will not say no. It's going to be very difficult. It's only a very small percentage of Indian citizens who would actually sit on Google and make a decision based on that, right? And so there was actual concerns on how doctors or people in positions of responsibility might be able to exploit people to be part of clinical trials. I'm not saying that is entirely true of this as well, but we really, really have to take informed consent more seriously than we do.
Yeah, and Googling health conditions, unfortunately,
actually,
invariably, it's a dangerous rabbit hole, because I always end up with cancer. Right? When I do that,
brain cancer, I think, is very prevalent. Amongst Google MDs. There's also this thing called biobanking, and biobanking research has been going on for a long time. And what we mean by biobanking is that people usually give a small amount of tissue or say a blood sample, and researchers will use that data to be able to understand, say, diseases in a particular population, or look at genetic variations among a population, right? For example, with cancer, a lot of the cancer tissue that gets biopsied or taken out can be given to studies to figure out better treatments, to figure out how the cancer is formed, etc., etc. And that is you giving over health data. It is health data that is captured in a database, and then gets used for a specific purpose. And when you actually set out those databases, you have to talk about what the purpose is. You have to get ethical clearances for keeping that data, and you're not allowed to share that data with anybody. You are not allowed to use the data for any other purpose without first getting an ethical clearance again. And the person who has given the data has the choice of withdrawing their consent at any point of time, after which you cannot actually use that data at all. So, I mean, even if you've gathered it and you have it in place, you can't actually use it. Those principles don't seem to apply to this policy at all, right? And this policy is very similar to that. You are collecting data with the purpose of improving your health landscape, which is an extremely broad purpose. You don't know who is collecting the data, where it is going to be collected, when it's going to be used, for what purpose. And all of those things need to be addressed now.
Yeah, I think that's a good point. And the other thing I think it's also worth talking about is the nature of the consultation itself, right? And I think that's, in my mind, that raised a lot of questions too, because this came out initially with, I believe, a 1 week timeline, 7 days to respond to it. Then it was extended by a week, and I think now it's been extended by another 11 days to September 21st.
Yeah.
Right. Which again, to me seems like, a subject of this important, right? That the fact that it can come out with a 1 week consultation is just amazing to me.
Well, it didn't surprise me as much, because last year we were working on the genetic editing guidelines for India, and that consultation was for 4 days. Yeah,
I mean, that's not that's not what the norm should be, right?
It should not be. We definitely on things of data privacy and the uses of health data, we need a bigger and much wider debate than the one we currently have. My suspicion is that maybe the National Health ID is something that could be used for the proposed vaccination, COVID-19 vaccination drive that we intend to have.
Potentially.
It would make kind of sense. This is just my suspicion. So I'm completely speculating here. And to have the data, because for the vaccination drive, one of the things that is going to be important is to be able to capture health data to ensure that there are no adverse events after the vaccination. It might be necessary to look at things like blood pressure or diabetes to see if you have comorbidities, and therefore when should you get the vaccine, right? There might be things related to that. And I suspect that putting this in place is necessary to be able to enable that data collection and safe delivery of the vaccine.
Yeah, that's a good point. And I'm just going to go back a bit, because you're talking about informed consent, right? And this is again something that struck me. If you actually go to the website where you can give feedback, right? There's a nice red line checkbox that says I agree to terms and conditions, which has no link. If you look closely enough, there is a section at the bottom which says policy of terms and conditions. But if you go to that, it basically says coming soon. And you need to accept the terms and conditions to be able to actually give feedback on this policy document. So yeah, that's informed consent.
Okay. I think we all agree that we need a bit wider debate than the one we currently have.
Yeah, that's true.
I think we can leave it at that.
Yeah. On that note, hoping for wider debate, let's wrap this up here. Thanks, Sunila. Thanks, Shambhavi.
Thanks, Prateek.
If you liked our show, don't forget to check out other interesting podcasts on the IVM network. You can tune into them on the IVM Podcast app, ivmpodcast.com, or wherever you listen to your podcasts. You can also follow IVM on social media. The handle is @IVM Podcasts on Twitter, Facebook, and Instagram. And hey, if you'd like to dive into Takshashila's research on technology, strategy, and economic affairs, check us out at our Twitter handle @TakshashilaINST or our website takshashila.org.in.
I hope you enjoyed that show. I'd like to thank our sponsors, Intel, for coming back to us. We love our sponsors. If you'd like to be one of them, do reach out. So really, really cool week on the network this week, right? Started off with a bang. Abhijit Ganguly was on Cyrus Says. Funny comedian. I think you guys will enjoy that. We had Dimant Parekh on Advertising is Dead. Dimant's the founder of Better India. Govindraj Athiraj is also on Uncle Please Sit this week. That's a really fascinating show which they talk about fake news. On the Habit Coach, there was a crossover event with Aditi Surana from Absolutely Right. I think you definitely enjoyed that. And last but not least, definitely a show I'd love you all to check out. We have a new show called This Round Is On Me. It's hosted by Gauri Devi Dayal. If you remember, Gauri and I worked on a show together called The Kolaba Cartel a while ago. Fun show. If you haven't checked that out, do check that out. But this is a show where she's talking to a lot of different people in the food space. Her first guest is Harsh Mariwala, a legend in his own time. I think you'll really, really enjoy that show. But with that, we hope to see you again next week.
Entertainment is like food for the brain. It's a window to culture and a great way to understand the world around us. The internet has changed what it means to be an entertainer, creating new storytellers with millions of fans. It has spawned a new breed, the story-sellers, those behind the scenes creating the business for this ecosystem. They work with brands, platforms and channels who are keen to capitalize on an audience hungrier than ever for more stories. I'm Vineet Kanabar, and I have a ringside view to how stories are told and sold. On my show, I bring you creators, artists, executives and marketers for a freewheeling conversation around the business of entertainment. Tune in to Storytellers and Storysellers for personal stories, analysis and criticism every Thursdays as I talk to the brightest minds telling or selling great stories today.